Moving on rather hastily to the problems of change, which I've depicted here in someone being lost in a maze, because that's the way it feels. Janoff Bulman wrote a book called Shattered Assumptions, in which she points up how we all maintain our peace of mind by believing in the idea that the world is a nice place where I know disasters happen, but they don't happen to me, they happen to other people. I know where I'm going and I know who's going with me, that sense of my life being meaningful. And almost a sense of being worthy. I'm being looked after by some God or parent or something or someone up there. This sort of idea of being protected is something which I think we all have, and we tend to take it for granted. Traumatic stresses shatter these basic assumptions. Quite suddenly, the nice world doesn't feel nice at all. Life seems chaotic, life seems to have lost its meaning, and you feel very vulnerable indeed, because God's not there for you just when you want him. That sense of being betrayed by them up there is very common at such times. Clearly, when people are feeling like this, it's no good saying, the danger's over, forget it. You never forget the experience of a major trauma. You have to live with it. Your assumptions about the world have to change. You don't go back to being the rather smug, person like you and me who are buoyed up by our illusions. I say you and me. No, probably some of you, at any rate, had the most horrific experience which have taught you about the dark side of life. It does exist. It can happen to any of us at any time. And we have to live with that. We have to accept that as a new assumption about the world. So coping requires modifying the old set of assumptions with new and more appropriate assumptions. That doesn't mean switching right to the other extreme. You don't go from being absurdly optimistic to being absurdly pessimistic to the rest of your life. I can remember during the war, the near-miss phenomenon. During the early stages of the war, we all were issued with gas masks and tin helmets, and we were taught about air raid sirens. We were told what to do when the siren went off. But before very long, we didn't take much notice. The air raid siren would go off, we'd look up. If there wasn't a plane in the sky, we just carried on with what we were doing. And then the bombs started to fall. And maybe the house next to you would be bombed, or someone in your family would be killed. And quite suddenly, from being absurdly confident, you went right to the other extreme. And that's what people meant by the near-miss phenomenon. The next bomb had your name on it. You rush for the air raid siren if a plane came anywhere near, these kinds of things. Only as time passed, people gradually began to get used to it again, and the people who'd experienced the near-miss phenomenon became a little less anxious. And I suppose what one can say is that as people come through, they begin to get a more real view of what is really dangerous and what isn't. They don't expect a disaster around every corner. But it's not surprising that in the early stages, mothers become very overprotective of their children. They become over-anxious about symptoms of all kinds and so on. So one can see how relevant this is. What can we do about it? Well, I think the first step is to get people to talk about it. While people are explaining themselves to us, they're also explaining themselves to themselves. You know, taking a case history is actually a therapeutic experience, because when you're explaining yourself to somebody else, you begin to get back in control. You begin to weigh up what's really dangerous and what isn't. And you begin to realize your own misperceptions. So that is itself quite a valuable thing to do. But it takes time to change one's assumptive world and develop a more realistic world. So people need that extra time. Since fear and anxiety are always present and hamper therapy, promoting a secure place and person where people will feel safe enough to talk about the things that make them feel very unsafe is crucial to any therapy. I've been worried to find out how often in hospitals there's no nice place where you can sit down with the family and talk to them without them seeing sort of pictures of skeletons or operating theatres or strange objects which they're not familiar with. A lot of hospices have developed relatives' rooms where they look like ordinary living rooms. You can sit down, there are comfortable chairs and flowers and things where people begin to feel safe enough to share their thoughts and feelings about the things that make them feel very unsafe. Since avoidance is present, we need to help people somehow to promote acceptance of the painful realities that they're beginning to confront. We need to treat PTSD, and we need to recognize that since low self-esteem, one's sense of confidence in oneself is undermined with this loss of confidence in the world around you. And it underlies a lot of chronic grief. And that means that what people need from us is respect rather than pity. Once you start talking down to people, you make them feel more weak and helpless than they were when they first came in. And our role is to help people to feel empowered, help them to feel their own value and their own worth, these kinds of things. So just to sum up then, any kind of bereavement can be accompanied by clinical depression. I'm not here talking about depression because that's not my role, but there is experimental evidence that antidepressants, such as phenelzine, do have limited benefits for PTSD, maybe the drug of choice when PTSD is associated with depression. Diagnosis and treatment will be considered in another session. So, just to sum up again, help yourself and your team. Trauma is infectious. We ourselves begin to be traumatized by the trauma around us. So we need to know what to do. Training for trauma is important for every doctor and every nurse. We need to know, to be empowered in a sense, as to how to react, what our role is in any traumatic situation. We need to learn to work as a team, not to feel we're the only one, to try to trust each other and work with each other and support each other. And we need to recognize that taking time out from the rescue operation, or whatever it may be, to talk about it with each other and with the support of maybe a senior person. Not just once. Critical incident stress debriefing, as it's being called, has been evaluated, and one-off interventions don't do any good, may actually do harm because they may generate problems which are not going to be dealt with. Debriefing is a continuing process which shouldn't just be left to one intervention. Helping others respect the differences between human beings, particularly people from different cultures who may react in very different ways that we are tempted to see as abnormal. We'll talk more about this in a later session. Giving the reassurance, explanation and support that we've talked about. Restoring control, giving people something to do, which is quite crucial, so that they feel that they're not left unempowered. Doctors are awfully good at taking control and doing things to people. We're not so good at helping people to do things for themselves. Value of rituals, which are often built into our society for times of disasters, whether it's a funeral or a memorial service, or simply going to visit a grave, these kinds of things do seem to have therapeutic benefit. And again, I'll talk some more about this in a later session.